I'll be taking you for like next 20 minutes how we treat recurrent head and neck cancer and what is our experience and what does up to date says that how to incorporate this targeted therapy, which is cetuximab, and to how to incorporate immunotherapy, which are PD-L1, PD-1 inhibitors in this practice. So 10 years down the line, we were like confused what is the most active chemotherapeutic cytotoxic agent in head and neck cancer. But now we have plenty of options. We have anti-EGFR cetuximab, we have PD-L1 inhibitors, nivolumab, pembrolizumab, and we have various agents of chemotherapy like platinums, taxanes, and 5-FU. And we now know the biomarkers as well, that which patient may respond to which agent. So this is the paradigm shift of chemotherapeutic and the targeted as well as the immunotherapeutic agents over last 40 years. So we moved on from single agent platinums to taxanes to combination of taxanes and platinum and became the famous extreme regime. We actually stayed for a decade and showed the superiority over the chemotherapy arm, which clearly said that the survival can reach up to 10.4 or 10.2 months. Then we have the data of checkpoint Keynote study 141, which say that when we add immunotherapeutic agents in the second line, our response rate can be again to the tune of 8 months, which was not seen with taxanes or methotrexate. And now in 2019-20, we actually talk about sequencing. We talk about how we can sequence these agents, how we can get the benefit of both targeted therapy and the IO agent, which should be used first with which combination to get the maximum survival benefit. So again, the previous slide, we moved from single agent to triplet, DCF, TAX324 studies and all, and then to extreme regime. So this was the extreme design, randomized 442 patient, 221 with a chemotherapy and chemotherapy plus cetuximab, clearly showing that cetuximab and chemotherapy combination had a huge disease control rate of 81% and a survival benefit of 2.7 months extra, 10.1 versus 7.4 in favoring cetuximab and chemotherapy arm. So and also it states that the quality of life was better when cetuximab was added. So this cetuximab and chemotherapy actually conquered the head and neck patients, these trials for a good 12 years. And we also know that some of our patients are not suitable for 5-FU. So in those patients, we incorporated taxanes or we incorporated taxane in the form of Paclitaxel or docetaxel. There are studies to it. And those patients who have a GI toxicity to 5-FU, we can omit cardiac and GI toxic patients, and we can still do better with a similar response rate and a similar overall survival, which was TPX study with cetuximab, taxanes, and the platinum. So multiple studies which showing that extreme trial, Vortex, SMET, extreme, and in the last is my study, which we published from Max Hospital, a study of 229 patients. So overall response rate and overall survival rate of 11 to 14 was seen consistently in all the cetuximab studies, whether it was 6-platin or 5-FU or whether it was taxanes incorporated. So this is TPE extra trial, TPX, which is like coming up in a very famous way, published last year. So extreme trial had 6 cycles of cetuximab, cisplatin, 5-FU, and TPX is cetuximab, docetaxel, and cisplatin. It was 4 cycles as compared to 6 cycles of extreme. And again, maintaining these responders with cetuximab weekly in extreme and 2 weekly in TPX trial. So TPX give us the daycare advantage. TPX give us no PICC line and no chemoport advantage, and also the advantage of giving cetuximab every 2 weekly, as we do in our colon cancer with harboring no pan-RAS mutation. So TPX and the extreme trial, again, they had similar overall survival, 14.5 versus 13.4 months, similar progression-free survival, which was 6.1 versus 6 months, and the similar toxicity rate. So why to admit these patients for 6 days, and it can be done clearly on a daycare basis with the same PFS response rate and the overall survival benefit. So this is our study which we published this year in January in head and neck journal, 229 data of 229 recurrent head and neck cancer patient, 140 got chemotherapy and cetuximab, and 89 were only chemotherapy, and we assessed overall response rate, PFS, OS, as well as the safety. So clearly saying that our overall response rates were higher than Western population. It was around 65%. And when we added cetuximab to the chemotherapy arm, the response rate increased to 77%. The PFS was with the cetuximab and chemotherapy, it was 8.1 versus 6.1. And the overall survival was also better, which was 10.5 months in favor of cetuximab and chemotherapy. The most important is that the partial response and the stable disease were higher in the combination. However, progressive disease was higher when chemotherapy alone. These are the Kaplan-Meier curves which came out of our cohort. So coming on, so now we have cetuximab and chemotherapy arm and this famous Keynote 048 study clearly saying that the first line immunotherapy can also be incorporated with chemotherapy or immunotherapy monotherapy, particularly in patients who have a combined CPS score of more than 20%. So this is design of Keynote 048, Pembro mono, Pembro with chemotherapy, which is cisplatin and 5-FU, and the standard backbone, which was extreme trial. So it was 1:1:1 randomization, huge number of patients, around 900 patients. So this paper says that around 43% of the patient actually had CPS more than 20, and 50% of the patient, when TPS was calculated, only 23% of the patient has TPS more than 50%. So this was the PDL1 breakage of this paper. This is the most important slide of the day. I would say that when our CPS is more than 20, so Pembro is better than extreme. When the CPS is more than 20, Pembro plus chemotherapy arm is better than extreme. This is very clear. However, when we come to less than 1 or 1 to 20 or CPS score less than 20, then this Pembro alone or Pembro therapy is not superior to extreme. So it matters only when we can do a CPS score, and then our Pembro monotherapy is, or Pembro plus chemotherapy monotherapy is better than extreme. But this again has some criticism, and this again has some points to say that despite the similar overall response rate to extreme and Keynote 048, the disease progression was higher when Pembro plus chemotherapy arm was given. We can see it was around 8 to 11% in extreme trial. However, the progression was highest, doubled up, even 17% with progression of the disease when immunotherapy was given. So the extreme is looking more credible. Extreme is looking more, we can say that around 40-60% of the patient, these patients will respond. However, the response rate with IO or IO plus chemotherapy was not great enough, and there were progressions. Again, Pembro monotherapy, the response rates with extremes are better than Pembro monotherapy, and the progressive disease with Pembro monotherapy is around 40%. So this therapy alone may not be that much credible if we compare to extreme paper. This is again an indirect comparison of TP extreme versus Keynote 048, 13.4 months in extreme, 14.5 months in TP extreme. However, the Keynote 048 says that it's 10.7, 11.5 with monotherapy and 13 months with plus chemotherapy. So our overall survivals are better or similar when we do not use this IO and we rely on our extreme, our 12 years data on extreme. So can Keynote 048 be extrapolated to Indian population? Is there a data to it? Yes. In last year, ESMO was a paper which clearly says that divided this group into Asian and non-Asian. And in Asian subgroup, the graphs were kissing each other. They were not significant. However, in non-Asian subgroup, the graphs were separating with a hazard ratio of 0.71. So Asian subgroup, upfront IO with or without chemo as a monotherapy may not be a great idea, and this is evidence to that. So again, response rates are, so the dark, the magenta bar graphs are the clinical trial and the pink ones are the real world data. And we have 3 data from India. My data of 229 patients, Dr. Rangaraju data of 35, and again RGCI data, which is Dr. Tiwari of 50 patients. Our response rate are to the tune of 50 to 70%. Survivals are also similar, which is 11.8 in my study, and Dr. Rangarao it was 9.2. So our data is equal Asian data, Indian data have seen such responses. So in this era, when we have NCCN 2020, which says that the CPS score is more than 21, you have various choices. So I would again like to have that cetuximab plus chemotherapy is my first line, then I give Nivo or Pembro as a second line, or my second option is combine immunotherapy plus chemotherapy in patients only who have a CPS score more than 20, but it also has those caveats of progressive disease. And later on, there's no data to suggest that post-IO we can use cetuximab or not. So this is a point of discussion, and we need many papers and many literature upcoming to solve this. So this is to answer this sequence, which is the best sequence. So they took the data of TP extreme and the extreme part, and this is extreme arm, this is TP extreme arm. 16% of these patients used IO when they progressed on cetuximab based arm. So I again emphasize, this is the again very important slide, extreme and TP extreme. Extreme use Erbitux cisplatin 5FU, TP extreme use cetuximab, docetaxel and cisplatin, and similar number of the patient got IO later on. And very interesting, I would say that, see this graph. So when TP extreme was used, when taxanes were used with cetuximab and then IO was used, there was a survival benefit. And when taxanes were not used, and again nivolumab or pembro was given after extreme, there was no difference in the survival. So there is no hypothesis to this, but I believe that the taxanes are causing some neoantigen shedding, and after TP extreme, if we use IO, we get a separation of graft. So very important, use taxanes with docetaxel, use taxane with platinum and the cetuximab, and later on use your IO. You might get a 14.9 month survival, which was not seen in extreme. So extreme and IO and TP and IO, that's the second part, was giving a survival benefit. So we need a more clarity on this 4A trial, second line sequential, PDL1, CPS, TPS, we should be more wiser, additional biomarker, response rate, progressive disease on Pembro or Pembro plus chemotherapy. We have to look at hyperprogression and combination of chemotherapy such as taxanes, which is coming up on a superior rate. Just touching on second line recurrent second line, if you have used cetuximab, and what would be your second line? So we have two drugs, nivolumab and pembrolizumab, approved, and we have data coming on atezo and durva and avelumab as well. So these are famous Checkmate 141 and the Keynote 055. Checkmate use nivolumab and Keynote use pembrolizumab. Similar structure, platinum therapy given, recurrent metastatic second within 6 months. So overall survival rate of around 7.5 versus 5.1 in Checkmate 141, and 8 months similar whether we use pembro or nivolumab in the second line. However, the progression-free survival was not great, and we know that in IO, OS matters, not the PFS, because it takes time. So another trial, HAWK trial, which is coming, our phase 2 trial of durvalumab in head and neck cancer, claims to have a 1 year overall survival rate of around 33%. And another study of a Condor study, which contains durva versus tremelimumab alone. So this also saying the overall response rate of around 10 to 15% in the favor of tremelimumab or the combination. So this is the final slide. The NCCN 2020 clearly say that irrespective of the marker, cetuximab, platinum, or 5FU and or the TP extreme in category 1, if we have a CPS score more than 20, pembrolizumab alone or pembrolizumab plus chemotherapy is also category 1. However, subsequent line we have to see whatever was being used in the first line, which we can use the later on in the next one. So both cetuximab and chemotherapy or pembro plus chemotherapy as category 1 as per NCCN. However, we have to see that how credible is pembro alone or pembro plus chemotherapy if we have to actually compare with extreme. Asian population, non-Asian population, there was a paper, but we need more data on that. Maybe we can all produce our IO data. So pembro plus chemotherapy may not be of a benefit in Asian population as in ASCO 2020. And chemotherapy plus cetuximab or chemotherapy plus cetuximab is again a flexible option, and it can be tailored to the patient, the daycare chemotherapy and the targeted therapy in the TPX1. Consistent benefit of PFS overall and OS seen with cetuximab chemotherapy combination, irrespective of PDL1. I not use this, and favorable safety and better compliance with TPX regime, particularly when 2 weekly cetuximab was given in this patient. And with cetuximab and chemotherapy, which allows a category 1 according to NCCN 2020, and nivolumab pembro is our fair second line option. So I think with this message, I conclude and over to the organizers.